So this area represents the capsulosynovial complex. And since we cannot study the anterior capsule and posterior capsule in the patient because of the coverage by the subscapularis and the infraspinatus, this is the most superficial portion where you can assess the capsule, the ligament, as well as the synovium. So the fluid from the glenohumeral joint also comes around the biceps. In fact, one of the most common cause for large amount of effusion is going to be adhesive capsulitis. So if you come now to the inferior recess, you see a thickening of the capsule. This is the normal side. This is your capsule on the normal side, barely seen. And if you see on the affected side, you find that it is much thickened. So here, if you find a reading of more than 4 millimeters, then that is thickened. If the reading is less than 4 millimeters, and it's more than 60% of the asymptomatic side, that also is considered as thickened. So these were these signs that we're looking for anteriorly. If you have to look for it posteriorly, just as Bill mentioned, you look for the posterior recess. And if you find thickening of soft tissue similarly there, or if you find that the movement of the infraspinatus during external rotation is not smooth, but appears jerky, or if the tendon is getting pulled down towards the labrum, those are signs of adhesions involving the posterior recess. No discussion of the shoulder is complete without looking at the bursa. So I just wanted to add a few slides here. So this is the deltoid. This is the peribursal fat. This is your underlying tendon. And here is the subdeltoid bursa. As you can see, it is not anechoic. It is not regular and smooth. It appears gray, so that is called hypoechoic. And so this is hypertrophy of the synovium. Synovial hypertrophy can be due to a mechanical cause. It can be due to impingement. So if you read up Neer's stages of impingement, stage 1 impingement is where you have only bursal thickening or bursal synovial hypertrophy. If the impingement progresses, the more pliable bursal surface fibers, they start fraying. So in this case, we are seeing there is a dip over here. So there's some amount of fraying of the bursal surface of the supraspinatus. And as this impingement progresses further, you can have partial or complete tear. So that becomes Neer's stage 3 of impingement. So this is a case of hypertrophy of the bursa, but there is no bursal effusion. We are not seeing fluid so far. If there's an effusion, it will appear, if it's an anechoic effusion, it appears as clear fluid. This I have taken at the lateral aspect of the humeral shaft. And normally you would find bursal fluid in this location between the deltoid and the supraspinatus. Here, this extension happens laterally. So when you assess for the bursa, it is not enough to see up to the greater tuberosity, because on the lateral aspect of the humerus, about 3 to 4 centimeters distally is the lateral extent of your subdeltoid bursa. It can also extend anteriorly over the biceps tendon. And so we should always assess all these regions before we say that the patient does not have bursal symptoms or bursal effusion. The posterior extent of the bursa is over the infraspinatus. So we are seeing over here between the deltoid and the infraspinatus tendon is the subdeltoid bursa. And below the infraspinatus, in this particular patient, we are seeing some fluid. This is the posterior recess of the shoulder joint. So you're seeing synovial hypertrophy over here. And if this patient had a tear, you would see fluid extending and filling up the bursa as well. So with this, I hand over to Bill to demonstrate for findings of adhesive capsulitis. Over to you, Bill.
Thank you, Dr. Meenakshi. That was an excellent demonstration of a lot of pathology. Very well done. So what we're going to do now is demonstrate really one of ultrasound's greatest features, and that is its ability to assess things in motion. We're going to look at some dynamic maneuvers and where they might come into play for you as part of your examination of the shoulder. I'm going to begin with something that I actually look at as part of my routine exam that Dr. Meenakshi covered in great detail. the rotator interval and the supporting ligaments that might be thickened in cases of adhesive capsulitis. So I look at the rotator interval and I start with the patient's arm down by their side. Now, if it's somebody with excessive lateral body wall mass and their arms out here, you might not be able to do that. You might have to bring their hand up further to their hip. But most patients that I examine, I can scan with their arm comfortably down by their side. This gives me the ability to rotate their, not them, but just rotate their arm as well to bring the bicep tendon down to where it sits right on top of the shoulder. I'm going to give myself a little less depth. I'm going to turn my gain down just a little bit. So now we're in the deepest part of the groove, but I'm going to take the transducer up and over the top of the shoulder to where we see it, as well as medially we identify the subscap, laterally we have the supraspinatus, and we have the bicep tendon positioned right in the middle. Now, say the bicep tendon is positioned more medially. And it's not where it's easily accessible. So you can take the patient's arm and rotate it so that you can bring the rotator cuff up. Also, I like this dynamic maneuver when you have a suspected bursal defect, because you can see the bursa sliding on the underside of the deltoid muscle with that dynamic motion of just rotating the full arm. So if there's a little bit of dipping of tissue into a bursal-sided defect, you might recognize it by doing this internal-external rotation maneuver and observing the bursa there as well. So what we have is, here's the coracoid and the coracoacromial ligament coming over and over the top of the bicep tendon here. So this is a place that you might measure it if you suspect thickening in association with a patient with loss of range of motion. The superior glenohumeral ligament comes behind. So we typically have this oblique relationship of the undersurface, pardon me, of this undersurface of the bicep tendon to the underlying bone. I mentioned earlier that we can do some dynamic scanning, looking at the supraspinatus as it slides back and forth under the acromion, looking for evidence of subacromial impingement, or, as Dr. Meenakshi mentioned, in cases of large bursal bulging, so to speak, calcifications, we can have the patient abduct their arm and see if that calcium might be knocking up against the acromion as the rotator cuff slides back and forth past the acromion. We're also looking to see if there's any any bulging of tissue as it slides back and forth there. Pardon me for just a moment. I'm just going to grab a little swallow of water to solve this tickle. We covered the dynamic maneuver that you can do to look at the subscap. So again, here we have the coracoid to the right, medially, and that dynamic maneuver that we can employ there. The axillary pouch is something that we can also look at by elevating the patient's arm. We're going to look in a long axis plane, and we're going to look in a short axis plane at this pouch to see if it's distended or thickened. So right now I'm in the short axis plane. I'm over the humeral head and neck. You can identify the inferior glenohumeral ligament and the middle glenohumeral ligament, and that area that you might measure would be here. And then you can turn the transducer in the long axis plane. You see the humeral head and neck here, and that capsular area is right in here, in this location here. Dr. Minacci, did I cover what we needed to cover on the dynamic scanning? If so, I'll turn it back over to you.
Yes, thank you so much, Bill, for this very excellent demonstration of all the rotator cuff tendons, the dynamic maneuvers, as well as the areas to be covered for the adhesive capsulitis. Yeah, that was really fantastic. So we come to the last slide, and so the take-home message would be that MSK ultrasound has a steep learning curve. You require good quality equipment. Today we worked on the Versana Premier machine. It requires technical skill, which Bill has amply demonstrated. We need a knowledge of range of normal appearances over different age groups so that we do not overcall abnormality. Dynamic maneuvers require use of both hands and needs a lot of practice. The limitations of ultrasound are mainly because of its limitation in evaluation of the bone structure. So type of acromion, the glenoid cannot be evaluated at all. Labral evaluation is limited to the posterior labrum. So there is a definite role for MR or MR arthrography in these cases. However, ultrasound has a lot of positive points in its favor. It's an excellent modality. It's a very widely available modality with no contraindications, acceptable to most patients, can detect wide range of abnormalities from tendinopathies, tears, calcifications, bursal inflammations, adhesive capsulitis, fatty infiltration, retraction. You can use dynamic maneuvers for impingement, subluxation, snapping bursae, labrum, and loose bodies. My request is to clinicians watching this presentation to discuss the case with your sonographer or your radiologist. Ask for dynamic scans to look for specific pathologies. That is what ultrasound is best for, and we can use dynamic evaluation to look for a number of conditions. So with that, we are at the end of our presentation. I hand it over to Nicole for any questions that there may be.
Thank you, Dr. Minacci and Bill, for those insightful presentations and the engaging live scanning demonstrations. We'll now begin the Q&A portion of today's webinar. If you haven't already, please feel free to submit your questions using the Q&A tool on your screen. Whether your questions are about techniques discussed, the live scanning workflow, or clinical applications, we'll do our best to address as many as possible. There were a few questions actually related to the coracohumeral ligament, and the request is that maybe Bill could clarify his demonstration of how this area is shown. While we're preparing for that, there is another question regarding any tips assessing the inferior recess in patients who are unable to abduct the arm. Dr. Meenakshi, are you able to give us some insight on this question?
So I find that patients who are sitting are unable to do it, and it's very difficult to assess the patient in a sitting position. So I make them lie down, I make them into an oblique position, and we could, most of the cases, we are able to obtain at least a long axis view of the recess because it is not very deep inside the axilla. Most people would try to put it right into the depth of the axilla and look, but basically you're looking along the anterior axillary fold. So just deep to where the pectoral is, you have to place your probe, and I think you should be able to assess the inferior recess.
Perfect. See some probe. Question was asked about the coracohumeral ligament, and let me try to demonstrate that again to assist you. I'm having the patient with their arm down by their side, just in neutral position, and placing the transducer in front of the shoulder, identifying the bicep tendon. I'm going to have her rotate a little bit to bring the bicep tendon over on top. Roll the transducer from here up over the top of the shoulder to where you see its interval, and you're demonstrating subscap medially, supraspinatus laterally. This is actually the bursa here. You see, if we rotate, you see how that all slides. But you see how this one ligament coming over the top of the bicep right here, that's the coracohumeral ligament, and that's the location where you might recognize some thickening and consider measurement. The superior glenohumeral ligament, conversely, comes back here behind the long head of the bicep. If we follow the coracohumeral ligament over, we can see its attachment to the coracoid. Dr. Meenakshi, is that correct? That what I showed there?
Yes, absolutely correct, Bill. And
Okay,
we have to measure it in external rotation, basically, because otherwise it is anisotropic and it is thickened. So when we measure, when we are actually taking measurements, we have to externally rotate the arm.
Okay.
Thank you both. We'll take one more question. The question is how to differentiate easily between deep and superficial muscles, particularly in emergency cases. Dr. Meenakshi, can you help us with this question?
No, I have not understood the meaning and which group of muscles he refers to. In any case, anything that is below the subcutaneous fat becomes superficial. Anything deep to that would be deep. But I've not understood exactly what the question is about.
So in relation to the subcutaneous tissue, that would be the superficial muscles, and the deep muscles will be deep to that.
Deep to that, yes.
All I would add to that is depth of penetration depends on the frequency that you're using of the transducer. Frequency of the transducer will determine how deep you're able to see. So for instance, if you have somebody come in with a hamstring tear in the emergency department, and they're looking at the deeper muscles, you might need a lower frequency transducer, sacrificing a little bit of resolution to get the depth of penetration you need for deeper muscles. The more superficial the muscle, the higher frequency can be utilized to get better resolution and yet still achieve depth of penetration that you need to. That's just kind of in general, you know, how you would approach deep versus superficial muscle assessment.
Thank you both. Dr. Meenakshi and Bill, thank you again for sharing your expertise and for the engaging live demonstrations. And thank you to everyone who joined us today. We truly appreciate your time, attention, and very thoughtful questions. Before we close, we kindly ask that you complete the feedback survey. Your input helps us improve future webinars. You'll receive a follow-up email with a link to the webinar recording. If you have any additional questions or would like to learn more about Versana Premier, please reach out to your GE Healthcare representative or complete the form available on the webinar platform. On behalf of GE Healthcare, thank you again and have a great rest of your day.